Okay, so I am Dr. Donna Session. I am a reproductive endocrinologist. I'm at the Wilmington Fertility Center in Wilmington, North Carolina, and we're part of the Boston IVF group. And today I was going to talk about some of the causes of infertility. So traditionally, infertility has been defined as trying to get pregnant for a year. In women over 35, we like to do the evaluation after about 6 months and after age 40 immediately. And the recent change has been that our National Society has become more inclusive about fertility. So we're also consider patients who are not in heterosexual relationships as infertile. It's common, 1 in 7 have infertility, so you're not alone. It just wanted to mention, if someone has other reasons for infertility, such as doesn't have regular periods or knows that their tubes are blocked, they shouldn't wait the year or 6 months to seek out help to get pregnant. So I was going to talk about some of the reasons why people have infertility. One of the common reasons in women is anovulation. That's when an egg isn't released each month. And so typically, if someone has regular periods every month, they are releasing an egg. If someone is skipping periods or going a long time without periods, and they're probably not releasing an egg. The way that people can check this is, one is the temperature chart. Some people will take their temperature every morning and plot it on a graph. And after someone releases an egg, the progesterone hormone goes up, and that raises the body temperature about 1/2 to 1 degree. And you can see that on the temperature chart. The reason that a lot of people don't do temperature charts is that it is very time consuming. Sometimes it's hard to tell that you have the temperature elevation, and the temperature goes up after the egg is released. So it's not really helpful for timing when to get pregnant, because by that time you've missed the window of chance of pregnancy. The other tests people can use are the ovulation predictor kits. And they can be good sources of timing things if people have difficulty, if they're in a heterosexual relationship and they have difficulty getting timing when to get together. That's useful. They are a little bit expensive, and sometimes for some people they're difficult to read. For example, if someone has high hormone levels like polycystic ovary syndrome, then they might be positive all the time. So it's hard for those people to tell whether or not they are releasing an egg or not. Typically, if people are not releasing an egg, there's going to be additional testing done, hormonal, to try to figure out the cause of this. And so there can be many reasons that people aren't releasing egg. Common hormonal things are like your thyroid gland, the gland in your neck is off, or something abnormal about the pituitary hormones. One of the very common causes of anovulation is polycystic ovary syndrome, where women have a lot of eggs, they're not reaching maturity and getting released each month. Other causes might be stress, exercise, and menopause, if there's not any eggs to ovulate. Actually, besides pregnancy, stress is one of the most common reasons that someone doesn't ovulate. And so usually we see that in young people in college around the time of their final exams or midterms, where they skip a cycle. So overall, ovulation is a factor in about 25% of women. Another common cause of infertility is tubal factor. So that's positive in about 35% of infertility. Is because the tubes are blocked. So the tubes can be blocked and in many ways. It could be a prior infection. Usually those are like gonorrhea, chlamydia. It could be other infections of the bowel. It may have been a ruptured appendicitis. It could be scarring from past surgery, or it could be endometriosis that causes scarring of the tubes. And we're going to talk a little bit more about endometriosis later. The tube, the fallopian tube, is what makes a path from the ovary to the uterus. And so that's how the egg gets into the uterus. And so that path, it's kind of like a stream because the tube is making fluid, and that's how the sperm sort of swims to the egg. And the end of the tube is kind of like a vacuum, and that's what picks up the egg and brings it to the sperm. And so if there's a blockage, then people are not going to get pregnant. But all the hormone and cycle is normal. It's just that it's just a roadblock. Most of the time, if people have a factor with the tubes, then the main option is going to be doing IVF or in vitro fertilization, because that bypasses the tubes. Sometimes people are a candidate for surgery. If there's not much damage to the tube, it might be able to be repaired with surgery. Another time that we see that improvements in chance of pregnancy, if people have what's called hydrosalpinx, that's fluid in the tubes. So the tube's usually making fluid every month. It peaks about the time of ovulation, so it kind of makes that stream for things to move on. But if the end of the tube is blocked, that fluid can't get out, and it just fills up the tube like a balloon. And so if people have a hydrosalpinx, that's going to lower chance of pregnancy spontaneously or even with IVF. So it's recommended that that tube's occluded prior to IVF. Or I've seen many patients where they have one tube blocked on one side and the other one's normal. I think the most common case where I see surgically is when there's been an appendicitis and the right tube is blocked and the left tube is normal, and because the appendix is on the right side. And in those patients, if we clip that tube or take out that tube, we increase the chance that someone's going to get pregnant spontaneously through the other tube. The reasons why we think that is the case is mainly that when you have a tube filled up with fluid, it backs up into the uterus and it flushes out the embryo into the vagina, and then people don't get pregnant. And then we can repair that with surgery, correct it. Another factor as far as fertility goes is age. And so we know that as women age, that they have fewer eggs and they have more abnormal eggs. And so women are not ever making new eggs. They're depleted throughout your life. I think of it as like you're born with a bank, and then you're constantly making withdrawals each month on your number of eggs. So how many eggs you start with depends both on your paternal side and your maternal side. So if you had a family that has like late menopause and kids late in life, you tend to have more eggs than the average person. But there's also environmental factors, because we know that, several cases of identical twins where one has a normal number of eggs and the other doesn't have any eggs. And so typically women are born with usually about 2 million eggs, and then it's about 500,000 at puberty and 1,000 at menopause. And so somehow the ovary seems to know how many eggs a woman has. And so if there's fewer eggs, then you make fewer each month. So normally women in their 20s make about 20 eggs a month, and then women in their 50s make 1 egg a month. And that group of eggs started 3 to 6 months ago. And typically what happens is one of those eggs gets released, and then the rest of the eggs get destroyed each month. And then there's a new group of eggs the next month. So the lower number of eggs doesn't really affect your chance of pregnancy very much. And so, but it does affect your ability to do, say, IVF, because IVF is not a very efficient process. And so you need a lot of eggs to do IVF, because we're just not as good in the lab as you are in the body. And the other issue with age is that there's more abnormal eggs. And so what happens is that if an egg's been sitting dormant for a long period of time, so the connection of the chromosomes is not normal. And so what happens is when the cell splits, you don't get an even number of chromosomes in each egg. And so normally what happens when an egg splits is all the chromosomes line up in the center, and then and they separate, and one set of chromosomes goes to one egg and the other set of chromosomes goes to the other egg. But if one egg gets 2 of the chromosomes, or another egg gets only 1 of the chromosomes, then they're going to be chromosomally abnormal. And so that's the reason why Down syndrome increases with age. And so if you get an extra chromosome 21 in one egg, then that's going to be result in Down syndrome. But there's, all of the chromosomes can be abnormal. So you can have one extra or one less of all of the chromosomes. Most of the time, if you're missing a chromosome, it never gets to the point of viability. So we don't ever see a positive pregnancy test. And then some of them, like Down syndrome, or some of them like an extra chromosome, like 18 or 16, might get to the point of a pregnancy, but then people typically will miscarry. So chromosome 21 is one of the few that gets to a live birth. And so since most of these eggs that are abnormal are never going to get to viability, if an abnormal egg is released, people are not going to get pregnant that month. And so since those are also contribute to miscarriages, then miscarriages increase with age. And so if we look at the amount of abnormal eggs, it's not sort of one particular cutoff like age 35, and then it's just a gradual change throughout life. And so if we look at the number of abnormal eggs, it might be like 35% of the eggs are abnormal in someone in their 20s, but you may be into the 40s, we might be getting into the 70 to 90% of the eggs are abnormal. So it's harder to get pregnant when more of the eggs are abnormal. And for the that's the same reasons why there's higher chance of miscarriage with age. And so if you're looking in your 20s, it might be a 10% chance of miscarriage, but by 40, it might be 50%, and by 44, it might be 70%. And so it doesn't say you can't get pregnant, but it says, it may take longer and there might be higher chance of miscarriages. That's very different than in men. And men are constantly making new sperm. And so every time a cell divides, there's a chance for error. So in men, it's more like new genetic disorders that are increased. And there have been some specific disorders that are associated with advanced age. Advanced male age is also associated with an increased risk of autism spectrum disorders and schizophrenia, and maybe even IQ in children. The way that we test for ovarian reserve, there are a few tests. One of them is we get the FSH and an estrogen level on about day 3 of the period. The FSH hormone is called follicle stimulating hormone, and the follicle is where the egg is. And what happens is if people don't have many eggs, that FSH level is higher. So it's like, I think it was like, the brain, the FSH comes from the pituitary gland in the brain. It's like the FSH is kind of like shouting at the ovaries to make more eggs. And so, FSA, a normal FSH is under 10, and women in the menopause, it's over 40. So if you have fewer eggs, the FSH is usually elevated. Another test we do is the AMH level. So that's the anti-Müllerian hormone. And that's a hormone made by where the follicles, where the eggs are in the ovaries. And so if you have more eggs, then the AMH level is higher. So another test. And again, I don't want people to think that these tests tell you can or can't get pregnant. I've seen people with AMH levels of 0 get pregnant. It tells us what are kind of the best options for people as far as what type of treatment might work. The last test is what's called the antral follicle count, and that's counting the number of eggs that people are growing. And usually these things are pretty consistent. Your AMH and your antral follicle count are usually pretty consistent each month. They don't change a lot, but they tell us what are good options for people. So, if someone wants to try IVF, we usually need more eggs because it's not very efficient. If someone wants to do fertility drugs, if there are a few eggs, then the fertility drugs might be helpful because the way they usually work is to get you to release 2 or 3 eggs instead of 1. And so if your egg count is 2 or 3, it still may be helpful to try some fertility medications. But again, that it's not a matter of telling you can or can't get pregnant. It's more a matter of telling you how the best way we can help you to get pregnant. The next thing I was going to talk about, male factor. So that's about 40% of infertility is male factor. So I think people are really surprised that it's almost half of infertility is male factor. And the way we test for that is the semen analysis. And so usually we're going to get 2 semen analyses because anything that's happened during the time that a sperm has developed can affect that semen analysis. So it takes about 70 or so days for sperm to develop. So the things that we usually think that might affect the sperm are things like high temperatures, like having the flu, or surgery, exposure to certain medications. So typically we're going to get 2 semen analyses, and if they're abnormal, refer someone to a urologist for treatment. So there are many reasons why there may be abnormalities in the semen analysis. Some of them are what's called varicoceles, or dilated veins. Sometimes there's a cyst that's causing blockage, and those things can be seen on ultrasound. So oftentimes the urologist will order an ultrasound, and those things can be treated surgically to improve the chance of pregnancy. Sometimes we don't see any sperm on a semen analysis, and those are usually due to blockages or lack of production, and those can be due to genetic disorders such as cystic fibrosis, or Klinefelter's is an extra chromosome, or maybe missing a part of the Y chromosome. That's called Y chromosome deletions. And those, the usual treatment is going to be surgery, so that a urologist retrieves sperm from the testis, and that can be used to do IVF. Other things that we see is if the sperm is going into the urine, that's called retrograde. Though that usually occurs in people who have neurological disorders, so problems with the nerves, like that typically occurs in people who are diabetics, and that's easy to treat because we can usually just give people Alka-Seltzer and then alkalinize the urine and then just do inseminations. But there's other medications that we can take in, such as Sudafed and antidepressants that can help that situation. So there are many reasons why men may have infertility, and like I said, usually the urologist is going to be the best person to evaluate that and determine what's the best option for men as far as treatment goes. As far as like uterine factors, cervical factors, it's very rare for the cervix to be a cause of infertility. If someone had an abnormal pap smear and had a leap or a cone, they may benefit by doing an insemination because they've lost the cervical mucus. The sperm, it does not live very long in the vagina, only about 6 to 8 hours. It has to get into the cervical mucus to survive and get to the egg. And so we can bypass that by doing insemination in those cases. The other uterine factors can be things that, like benign growths of the uterus, like polyps. We know that polyps lower chance of pregnancy, and we know if we remove polyps, that's just a minor outpatient surgery, will increase chance of pregnancy. Fibroids are also benign growths of the uterus. It really depends on where the fibroid is. I say it's location, location, location. So if the fibroid's on the outside of the uterus, it's really not going to impact the chance of pregnancy. If it's on the inside of the uterus and it's significantly distorting the uterus, it might lower chance of pregnancy or more likely increase chance of miscarriage. And so there may be an indication for surgery to remove the fibroids. As far as other causes called peritoneal factor, peritoneum is the lining of the inside of your abdomen or your stomach. And the factors for the peritoneum are there might have been scarring from prior surgery or from infections like an appendicitis. But the one that we think is probably most common is endometriosis. And so endometriosis is present in about 35% of women with infertility. If women have infertility and pain, it's much higher. It's going to be maybe closer to 80%. And so endometriosis is when that inside lining of the uterus that's usually shed each month when you have a period, it goes back through the tubes, and then it sticks to places where it shouldn't be. So around your tubes and the ovaries, and that causes a lot of inflammation, which is not a good environment for eggs or for sperm, and can lower chance of pregnancy. Endometriosis can also lower chance of pregnancy by causing scarring. And so we don't do a lot of surgeries for endometriosis anymore like we used to, because the surgery doesn't really bump up chance of pregnancy a whole lot. And if someone goes to IVF, if they're a candidate for IVF, they're going to have a much higher chance of pregnancy doing IVF. So if someone does surgery to remove the endometriosis, maybe you'll increase chance of pregnancy from 3 to 4% to 5 to 6%. But if you go to IVF, you might be on average closer to a 50% chance of pregnancy. We really would reserve surgery for people who may be having a lot of pain. It's not a guarantee for pain relief, but most people are going to have pain relief if they have surgery and have the endometriosis removed. Also, if we think there's a cyst there that might interfere with the IVF and collecting eggs, or may not be a cyst that we think is benign, then we're going to recommend surgery for those patients. The chance of pregnancy after surgery still remains, even out a year after surgery, we still see chances of pregnancy. One of the problems with endometriosis is we don't know what causes it. So it frequently comes back, and it might be back about 50% of the time in about 5 years. So we try to get people, if they're having surgery, so to take advantage of the time shortly after surgery to try to get pregnant. Some of the medications, that we use in fertility can make endometriosis worse. And so endometriosis is stimulated by estrogen. And a lot of the fertility drugs that we use, like clomiphene or injectable meds, can increase your estrogen. They can make it worse. They can have more pain. So we usually will use something like letrozole. So that's not FDA approved for fertility, but letrozole actually works by lowering your estrogen. So in patients with endometriosis, that might be a first line to try to minimize the effect of endometriosis by not worsening pain or causing it more growth. Unexplained infertility is only about 10% of the people with infertility. It's like, we've done all the testing. We don't know why people are not getting pregnant. People often start with a combination of fertility medications and insemination and when it's unexplained. But the real significant increases in chance of pregnancy are if someone is going to do IVF. We think the reason why is because we can do things with IVF that we can't test for. So, for example, someone might have a fertilization problem, and that could be an egg problem, or it could be a sperm problem, more likely sperm. But and so with IVF, we can pick up a single sperm and put it into the egg. That's called intracytoplasmic sperm injection. Sometimes we notice that the embryos are not hatching. So human embryos have a shell around it. It's called the zona. And then we can hatch that embryo and help people conceive. The other things with IVF, you're bypassing things. So maybe there is something inflammatory, or like endometriosis that we don't see that might be lowering chance of pregnancy. So for all those reasons, IVF is going to have the highest chance of pregnancy. As far as environmental things lowering chance of pregnancy, we know that smoking lowers chance of pregnancy. We also know that secondhand smoke affects chance of pregnancy. There's other things like caffeine in women, not in men. It improves sperm movement in men, but in women, it takes longer to get pregnant, and it has associated with a higher chance of miscarriage. Lubricants like KY jelly and Astroguide affect sperm motility, so they might lower chance of pregnancy. NSAIDs like Advil, Motrin, Aleve they might trap an egg inside the ovary so it doesn't get released, and aspirin may do the same thing. Acetaminophen or Tylenol shouldn't affect the ovulation from the ovary. Alcohol is not very strong. Maybe 2 drinks a day might affect chance of pregnancy, but it's not a strong factor to diminish the chance of pregnancy. But those are some of the environmental factors that might lower chance of pregnancy. And so at this point, I'm going to just open this up to questions about the causes of infertility. I can pull up the question and answers. So one of them, the first one is, does autoimmune diseases cause infertility or affect fertility? That's still pretty controversial. And so I would say that the majority of the data on using things to affect autoimmune diseases, I think overall in the reviews have not shown to be too particularly helpful as far as improving chance of pregnancy. For using OPKs, ovulation predictor kits, usually we don't use the first morning urine. It's better if it's done later in the morning. And so I think it may vary based on the type of kit you use, but usually we say not the first morning and use it the later one. Let's see. Oh, sure. This asks if we see patients that are seen elsewhere. Sure. I mean, we're happy to always give a second opinion, review the records, and even if someone wants to transfer care, we can always transfer care here. And we even have patients, if they have embryos, transfer embryos in if Boston IVF transport team reviews them and feels that it's acceptable to review them. The Wilmington Fertility Center takes TRICARE. And if it's something that's not covered, one of the really nice things about Boston IVF is that they have a military discount. And so I'm not, don't quote me on the numbers, but it may be like an IUI cycle might be $1,500, but if they have a military discount, it might be like $800. I think it's like a 25% discount. But when I've mentioned that to people that we have a military discount, it seems to be very appreciated that we can do that. And so let's see. So this is that's a complicated one. And it is a repair of a C-section scar. And so, for me, I don't know exactly why they feel that's lowering your chance of pregnancy. I think if it's filled with fluid, that might be affecting the chance of pregnancy, just like a tube that's filled with fluid. And sometimes it can make it more challenging to get an embryo into the uterus if the catheter gets caught up into the C-section scar. That's more challenging. It also may be that they're concerned about having a window because that's a weakened area, and they're worried about the rupture of the uterus in pregnancy or if there's labor. But I've had patients have that corrected surgically. It's not a common surgery that's performed, and most people that I see are minimally invasive surgeons. And so I've referred patients in the past to have that surgery done. Okay. So how do you usually treat polycystic ovary syndrome? So typically with polycystic ovary syndrome, the highest chance of pregnancy is going to be with the medication letrozole as a first line. So their studies, I think, are pretty clear when you compare clomiphene to letrozole that the chance of pregnancy is higher with letrozole. We also usually use a combination of the letrozole with the diabetes medication, metformin. We know certainly with Clomid that metformin is going to increase the chance that people ovulate, and it also might decrease the chance of miscarriage. So that's my first line is letrozole and metformin for polycystic ovary syndrome. Could bringing on a period affect the amount of eggs? Probably not. And so Provera is a medication to induce a menses. Typically, it's taken for about 10 days. It shouldn't affect the number of eggs you have. Typically, we do see combination birth control pills lowering the number of eggs that we see on the ovaries. And so some of it is just that the follicles are smaller and maybe harder to see on ultrasound. But we also know with IVF, if people are on long-term birth control pills, it may lower the number of eggs we collect with IVF. So when we do birth control pills before IVF, we try to minimize the amount of time people are on it. Let's see, this says, what's a timeline for IVF? I don't know if that means how long it takes to do IVF. IVF takes about 2 weeks. It's really is a time commitment. It is about 2 weeks. So you're not sort of at the office for the whole 2 weeks. So typically ultrasounds and blood tests are done about every other day. And those are quick, about 15 minutes. You get a blood test, you get an ultrasound, it's early in the morning. It needs to be early in the morning because we're waiting on the results of the blood work to come back to know what medications to take that night. So maybe the ultrasound might be, 7:30 to 9:30 in the morning. And then on average, it takes about 10 days for the eggs to grow. And so we're looking at the ultrasound and we're looking at the estrogen level to see when the eggs are mature, when they would be ready. And some people go fast and it's like 8 days, and some people go slow and it's like 12 days. Usually we don't collect the eggs or trigger before day 8 because the eggs tend to be immature, and immature eggs don't fertilize. And usually we don't go past day 12 because then the eggs get post-mature and they end up being poor quality embryos and have a lower potential for chance of pregnancy. On average, it's 10 days. And then people take the trigger shot, and then usually we collect the eggs on day 12 on average. And that collection is done under anesthesia. So if people are trying to plan when to be off work, it can be a little challenging. But if you figure it's about a 2-week window, you can kind of figure out when it's a good time to do the IVF. So I have accountants who do it after tax season, and I have teachers who do it in the summer when they feel like they can have a little bit more flexible work time. We typically try to transfer the embryos 5 days after we collect the eggs, unless people are going to be doing genetic testing. If they do genetic testing, they grow the embryos out to day 5, 6, and 7. And the embryos biopsy that's sent off for genetic testing, that takes about 2 weeks to come back. And once we know what the genetic testing is, then we can plan to have a frozen embryo transfer. So says, does AMH reflect all the eggs or only? So AMH is the growing follicles. It's made from preantral to antral follicles. So it isn't a measure of the total number of eggs or the ovary, but the number of eggs you have growing each month is a reflection of the total number of eggs. And so if someone's growing 20 eggs a month, they probably have about 500,000 eggs in the ovaries. If someone is growing 1 egg a month, they may have about 1,000 eggs left in the ovaries. So this question's about caffeine. So, we used to say probably 1 cup a day was okay, or less than 100 of caffeine was okay. The current recommendations are no caffeine now because of the increased chance of miscarriage and the smaller babies, and it may also affect adult height. We do know that the more caffeine a day, that the higher the chance of miscarriage and the lower the chance of pregnancy. We don't know what the reason is, the physiology for why there's a higher chance of miscarriage. There was some research on something similar to caffeine that was in the Oregon Primate Center, and then if they're exposed to that, the eggs were immature, and so that's the eggs that are immature don't fertilize, and so that might be a factor. In those studies, they included coffee, teas, sodas. They even included chocolates, but you'd have to have a lot of chocolate to have a significant amount of caffeine. I think decaf is okay, because I think there's such a little amount of caffeine in decaf that probably wouldn't be affecting your chance of pregnancy. Let's see. What do you recommend doing before and after an IVF transfer to improve success? So, the things that we're focusing on before the transfer is really medication to prevent you from having a cramp, because what we're concerned about is if you have a cramp, you could expel the embryo into the vagina and you're not going to get pregnant. So the best data is really for progesterone. So people are usually taking progesterone. We have people do a progesterone capsule start at 8 a.m. in the morning of the day of the transfer. The other things we use are things like Valium. There is less data on Valium, but the thought is that it relaxes the muscles of the uterus so that you prevent a cramp. After the transfer, back when I first started training, we thought people should bed rest after the transfer, but there's, I think, decent evidence that's saying if you're doing normal activity, like you're walking or you're swimming, you're going to have a higher chance of pregnancy than if you bed rest. I think there's good data that says that you can stand up after a transfer, you can go to the bathroom after a transfer, you can walk after a transfer, and you're not going to lower your chance of pregnancy. So this was a question of how much does IVF success depend on sperm quality, and I think it's a good question. And so there is more recent evidence on sperm quality. I mean, people have done testing in the past on sperm DNA fragmentation, but what's recently come out is that if there's a shorter duration of abstinence, that the sperm DNA fragmentation normalizes. So what I've been doing, this data probably at least when I heard of it, probably was 5 or more years ago. And so we try to tell people is to have 24 hours of abstinence. And so to ejaculate the day before we do the egg collection, or same thing before IUIs, to have more frequent. So, and if people are having intercourse, it's recommended to have intercourse every day for the 4 days leading up to ovulation to have the best quality sperm. There's other ways that we might be able to improve the sperm quality. And so one of those is what's called PICSI. And that's where we have a dish, it has something on it like hyaluronic acid, and we can use that to pick sperm that we think might be better quality. So if we think maybe someone's past IVF success might have been related to the sperm quality, we might opt for doing PICSI in that cycle. What's the difference between IUI and IVF? So IUI is pretty simple. So IUI is also called insemination. What we do is we wash sperm, and it can be donor sperm or it can be your partner sperm. And then it takes about an hour or so to wash the sperm. And then we just place the sperm in the uterus. And so it's pretty simple. It's kind of like a pap smear. You might have some spotting or cramping or rare chance of infection because it's a very soft plastic catheter. Takes about 10 minutes to do an IUI in the office, and it doesn't restrict your activity in any way. So, you know, a lot of times we do the IUIs close to lunchtime. So usually, you know, if there is a male partner there, they're there early in the morning around 8 o'clock, and maybe it's close to the lunchtime when we're doing the insemination in the office, and it takes 10 minutes and then you're out, and it doesn't really affect your life very much, and very low risk, and it also tends to be fairly low cost. But chance of pregnancy with IUI in someone who has infertility is not as high as it's going to be with IVF. So maybe if someone takes fertility medications plus an IUI, they might have on average about a 10% chance of pregnancy, where on average with IVF, people are going to have about a 50% chance of pregnancy. So IVF is where we collect the eggs, and then we inseminate them or fertilize the eggs in the laboratory, and then transfer an embryo back to the uterus. And so that is, as I mentioned, much more time consuming. It has more risks. And then it also is much more costly if you don't have insurance coverage to do IVF as opposed to IUI. Can a history of having an ovarian cyst burst cause infertility? I mean, we see lots of people with cysts. We see lots of cyst bursts, and I haven't seen many cases where it affected fertility. I suppose if it, depending on what type of cyst it is and whether it caused any scarring or inflammation, that could be possible. So a history of an ectopic pregnancy is sign of tubal blockage. I mean, if someone's had an ectopic pregnancy, you know, usually we're going to check the tubes. Usually that's going to be the hysterosalpingogram or the X-ray test to look to see if the tubes are open. If someone's had one ectopic pregnancy, they are at risk, even if the tube's normal, they're appearing on the X-ray test, they're at risk for a second ectopic pregnancy. Sometimes if the tube was even removed, there's a risk of an ectopic pregnancy in the other tube. So it's somewhere around 10% or so. So it's still a 90% chance that the pregnancy is in the uterus, but you're going to have about a 10% chance of a pregnancy in the tube. So we try to identify it early. So hopefully we can treat it medically rather than surgically. No, there's no doubt though that if someone does IVF, that their chance of a pregnancy in the tube is much lower because we're bypassing the tubes with IVF. says, I can't take metformin anymore. What can we use a place? And I guess the reason is, why can't you take metformin if it's something like kidney disease? I think that's reasons why it can't be done. What metformin's doing is lowering the insulin, and insulin is what prevents people from ovulating. And so I think other ways to lower insulin is weight loss. And sometimes it doesn't take a lot of weight to make a change in ovulation. And so our program works with some of the online weight loss places that can work with dietitians and other medications that might be helpful. Some people will even opt for bariatric surgery if that's something that might work for them. And if metformin's being used for a diabetes medication, then there are other alternatives to treat the diabetes, but usually that I would refer people to medical endocrine rather than manage diabetes. So this person was asking, been taking birth control pills continuously, and so does that decrease the egg count? Well, actually, if you take birth control pills, it's not a lot, but you actually do preserve some of your eggs. Maybe you delay menopause about a year. So you're not losing more eggs by taking birth control pills. You might be preserving some, but you're not preserving a lot. So typically when people are on birth controls, they're still cycling. Most people are still cycling every month. They're losing their eggs. And even in pregnancy, people are cycling and still losing eggs. So I have some people think, well, I took birth control pills for 10 years, so I should have all my eggs, but that's not the case because you've still been using them up. The one is, it is harder to see them on ultrasound. So I think that when you're doing an egg count on someone on birth control pills, you might be estimating the number of eggs, the antral follicle count, and also AMH is lower on people on birth control pills. So you're probably underestimating the real ovarian reserve if you're on birth control pills. And sometimes if people can come off them for a little while and reassess the ovarian reserve, because it might be improved. It does lower the number of eggs we get in an IVF cycle, but not a lot, maybe 1 or 2 fewer eggs. Typically people don't have a response that has very few eggs on it. And because most IVF cycles, we use birth control pills to get the IVF cycle started, but you're not using up any more eggs on birth control pills. You may be preserving some, but not a lot. Does weight have an effect on getting pregnant? Yeah, we do know that if people's BMI is lower, that there is a higher chance of pregnancy. So maybe the cutoff may be around a BMI of 28. Under that, you're going to have a higher chance of pregnancy. Over that, a lower chance of pregnancy. And we don't know all the reasons why. We know if people are overweight, it's kind of an inflammatory disorder. We do know that's very clear that if people are overweight, that you need more medications. And so we think it's just a matter of distribution. So if you are taking an injection and you have this number of cells that it's just, that it's dispersing, that it's just harder to get a higher level of hormone to the ovaries. And so we do know that if people are overweight, we usually do a little bit of a higher dose of medication. And also that has been correlated with a higher cancellation rate. So if someone's overweight, they are more likely to have their IVF cycle canceled because they don't make that many eggs. See, my partner has a low sperm count. Is there anything we can do? I think that kind of depends on the count and what the other things that the urologist finds. We can the urologist is going to usually get hormone tests, usually get an ultrasound, see if there's any things they can do surgically, whether or not they can do things hormonally. It's pretty rare for men to have sort of the exercise causes of stress causes of low sperm counts. It's pretty unusual for them to have hormonal things like your thyroid or prolactin that are commonly abnormal in women to be a cause of the infertility. Many of the urologists will do treatment with the same fertility drugs that we use in women. So clomiphene or things like letrozole or HCG injections. So those things might be beneficial if it looks like the person might be a candidate for those things. So the cervix, person cervix is stenotic and have difficulty with catheter insertion with an IUI. Do you recommend Valium prior to frozen embryo transfer or transfer under anesthesia? So usually if it's difficulty getting the catheter in because of cervical stenosis, then usually what we're going to do ahead of time is dilate the cervix. So what we're concerned about is that there would be bleeding at the time of the embryo transfer. And there are, it's controversial, but there are a number of studies that say if there's blood at the time of the embryo transfer, it's going to lower your chance of pregnancy. In addition, if it takes longer to get in, we know that, I have about 1.5 minutes from an embryo getting out of the incubator to getting into the body, and then they start dying off pretty quickly. And so if I can't get that catheter in quickly, then you're going to lower your chance of pregnancy with IVF. I don't know that Valium is going to change a stenotic cervix. And so I give everybody Valium before the embryo transfers, but that's more so people don't have contractions. Usually if the issue is that it's stenosis, typically what I'll do is dilate the cervix at the start of the cycle. And you can't dilate the cervix in the middle of the cycle. There was a study back, I think 1996, where they were dilating the cervix at the time that we collected the eggs, and we know that lower chance of pregnancy, where they were doing the mock embryo transfer at that time. And that definitely lower chance of pregnancy. I think because you disrupt the lining of the uterus, you get blood there. So what I do is have the patient, when they come in for their baseline ultrasound, that I'll just use a soft plastic dilator to open up the cervix. And then that usually lasts. Sometimes I see that last for 2 or 3 months, but usually I'm going to do it at the time of the start of the cycle. I've had some patients where it's really challenging. And I've even taken them to the operating room and then dilated it. I mean, it's too painful with the large metal dilators to do that really in the office. So I have people go under anesthesia and then dilate the cervix, and that will even stay open longer. So I've seen the cervix stay open up to a year after dilating the cervix. There are some cases where people go in and resect some tissue to open it up. That's sort of out of my wheelhouse, at my comfort zone, really, as far as I'm too worried about getting scarring, because once you scar the cervix, it's really difficult to correct the scarring. I have done embryo transfers under anesthesia, if in case where there's some really difficult embryo transfers, but has been pretty rare. Most of the time, if I dilate the cervix, that works. And the other times, if I've had really difficult embryo transfers, I'll put a stitch on the cervix prior to the transfer, and I use that to hold the cervix, and sometimes that straightens it out and makes it an easier path. Let's see. It says, I diagnosed with endometriosis, and should I see a fertility doctor now or wait till after the surgery? Well, most of the people I see get pregnant pretty soon after the surgery. So I would say you might want to, see at the time of the surgery how extensive the endometriosis is. Is there any scarring? Is there any reason to go to IVF versus to try on your own? But I would say if you're not pregnant in a few months after the surgery, maybe then see someone, because there might be some things that people can do to bump up chance of pregnancy without really worsening the chance of endometriosis returning. We're always concerned that the longer people wait, the greater the chance that it's going to come back. Maximum age. So is the maximum age to do IVF I mean, I think Boston IVF has a cutoff of age 45. And so although they do allow you to do a cycle, one cycle after 45 if the person wants to try. And that's IVF, autologous using your own eggs. And so as far as things like, donor egg or donor embryo, those typically will go to age 50. So it's really where your comfort is as far as, what your success is going to be with IVF, what, how you feel about having miscarriage, how you feel about having a child with Down syndrome. It's kind of a personal choice, but we know that age is a strong predictor of success of IVF. So you might be looking at someone in their under 35s being the 50 to 70% chance of pregnancies. And then it really starts declining at age 38. And then by the time you get to age 40, the chance of pregnancy is probably around 30%. But by the time you get to 44, it's probably down to about 1 to 5%. And then if you get pregnant, you're going to have a fairly high chance of Down syndrome, and your miscarriage rates at 44 are going to be 70%. So if someone goes into this knowing, okay, I don't have a great success and I have a higher chance of miscarriage and a higher chance of Down syndrome, but I still want to try with my own eggs, then we'll let people try a cycle after the age of 45. Well, that's it for questions. And good night for tonight. So thank you for all of the people who attended and asked questions, and I hope this was helpful.